Hi, everybody. All right. Hi, everybody. I am Julie Matheny. I am a speech pathologist and IBCLC lactation consultant. And today we have a really special treat. I am going to be inviting Nat the Baby OT to come on and join us. Let me see if I can find.
Oh, wait, there we go. There's Nat. It
I
worked.
exist.
You
Woohoo!
exist. The miracle
Yeah.
of science and technology.
Yeah.
I'm so
So
glad
much.
you're able to join us.
Thanks. Likewise.
Yeah, because I have known about you for a couple years now from mutual occupational therapy friends, and I've sent a couple babies virtually to you, and
Yeah.
I'm like so
You sent a
excited to
few.
actually
Yeah.
see you in the
Uh,
flesh.
well, here I am in a hoodie. In a hoodie, but
In a
close.
hoodie. I'm in
Yeah.
my Scooby Dooby Doo scrubs today because I'm going to see
Cool.
home visits. So, hello, everybody, again. I'm Julie Matheny. I am a speech pathologist and IBCLC board certified lactation consultant. And we have today.
I am Nat. I'm Nat Udwin, Natalie Udwin, but most people call me Nat. And I am an OT. So I am an OT. I practice in Atlanta and also do lots of things virtually. So
Yeah.
I am here on Instagram, and you can find me here, I guess. So,
Awesome. So
yeah.
tell us now, you and I obviously know our field. We know that speech, physical, and occupational therapists can work really womb to tomb, as I like to say. We can work with neonatal day old babies all the way through 105-year-old geriatrics. We can be in all kinds of settings. Tell us a little bit about what you specifically do in the occupational therapy
Cool.
world.
So I mean, it kind of depends on who's asking what I do, but basically I tell people I'm a pediatric OT and I specialize in infant feeding and development. So that was totally an accident. I started out as a peds OT about 12 years ago now,
Mm-hmm.
and I had my own practice in Nashville, and I kept getting stuck with my big kids. And long
Mm-hmm.
story short, I knew we had to keep working on basic developmental skills that we should have we should have fixed, or they should have developed correctly in that first year of life. And I started taking more courses about infant development and about those early years and tummy time classes and all those things that really opened my eyes to what I was missing. And babies kind of accidentally became my thing. So I still work with big kids too on a limited basis. I've actually started seeing younger ones now just because I can't handle the jumping back and forth between big and small and all day long. But yeah, I mean, I'd say at least 50 to 75% of my practice weekly is infants under the age of a year old.
And
And
now
so,
you and I
yeah,
know what physical
yeah. So
therapy,
I was
occupational therapy,
going to
speech
explain
therapy look like.
what do we
Yes,
do?
tell us about what that
Yeah.
looks
So the
like
next
in the
question
baby
is
population.
like, what the heck do you do? Like, people kind of get what speech does. They sort of get what PT does, but they have no clue what OT does, especially with babies. I met an old friend of mine this weekend. I ran into him, and he works in the medical field, and he was like, you do OT with babies, but how do you get them to participate? Like, what does that even look like?
Yeah.
And so, yeah, so OT basically is, we work with the nervous system, we work with the brain, we work on development, and we're very much like the holistic, not that other therapists are not holistic, but we are trained to look at the whole body. And so we look at how everything fits together, and essentially, how does that help you function as a human being? And so from a baby perspective, like, the word occupation is annoying, but basically occupation means whatever you do, right? Whatever you do, whether you're a mom, whether you're a teacher, whether you work in the government, like, it could be a paid job. It could just be the role that you play that hour of that day. And baby's job is to eat, sleep, poop, and socialize, basically. And my job is to figure out where things go wrong, if something is difficult for them, and to put those pieces back in place so that we can reroute that journey to a more normal, like, optimized state. So, with babies, most of my babies come to see me because they don't eat well, but a good handful of them also come because they're not moving well. Or I also get the referrals that I get that are different from PT and speech usually, are the babies that are super dysregulated. So, like, your colicky, cranky babies that can't be put down, they're just uncomfortable in their skin. Those babies are OT's dreams, at least infant OTs. We love those ones because they are tricky, but they are in our wheelhouse and we have the tools to deal with them.
Now,
So
talk to me about that, right? Wheelhouse tools. in my world, speech lactation, I'm seeing tongue ties and pump flanges are like my predominant. Those are my wheelhouse.
Okay.
That's my jam. When I
Sure.
have a dysregulated baby, I'm like, go see my
Yeah.
OT friends in
Yes.
the area.
Okay.
So
Yeah.
talk to me just a little bit about like 2 or 3 things that you would do in your wheelhouse to help with those dysregulated babies.
I mean, first we have to figure out why.
Yeah.
Like, why are they so cranky? You know, so that's my whole job. Like, we're kind of we're detectives, you know, and I mean, in all of our, especially, I guess in therapists in general, when we're working with development, like we have to rewind to see like, where is this really breaking down? And so my job is to get a really detailed case history from the parents and figure out, okay, like what's really happening here? Like, you know, the parents are saying, well, they cry every time I put them down, but why? Is it positional? My job, I'm looking for patterns, always looking for patterns. Patterns of behavior, patterns of movement. Why are they doing this? How are they moving? When are they moving like this? And then my job is to piece out what's causing this to happen. And so a lot of times there's a GI component to it. But then GI can also mean, okay, well, we're swallowing too much air. So now there's a latching component as well. And so then we have to address the oral function, but in order to improve the oral dysfunction, then we have to address like the physical, you know, an asymmetry or torticollis, and it's the holistic thing. Yeah. Yes. So I'm always rewinding it, like to see like, okay, so what caused this, and then what caused this, and then what caused this. And we really have to put that foundation in place first. And if that foundation is there, then we can build all the skills we need on top of it. And regulation is a part of that, because I mean, we're uncomfortable because something's not right. You know, that's as simply put as I can say it. So
yeah, no, I love it. Now, I obviously see a lot of tongue tie babies, and we'll often have parents in the parent forums be like, my baby has a tongue tie. What do I need to do? And then you'll hear body work. And it's kind of this like mysterious, like, ooh, what is body work, right? So in my role, what I'm often saying to parents is there's some foundational skills that have to happen for feeding to take place. We need to have symmetry and alignment, postural support. We need to have range of motion, strength, and coordination. So when I see a baby, whether it's just a symmetry issue, like their head's just a little turned from birth, right? They came out of the birth canal a little wonky. Yeah. A lot of times I'll say body work in that case is let's go do 1 or 2 sessions of chiropractic or craniosacral fascial therapy, right? Get a little symmetry back. And then when I have babies that have done 1 or 2 or 3 sessions of chiropractic, and I hear the parents say, well, they're fine for a day or 2, and then it doesn't stick. Yeah. That's when I'm like, wrong modality. And the body work that I'm then sending to is occupational and physical therapy, because you're working not only on symmetry, alignment, postural support, but range of motion, strength, and coordination. Totally. Do you have any other kind of comments on that vein of body work?
Yeah. So, I mean, the thing that I've been telling parents for years is that I don't work on babies, I work with babies, because a lot of times they'll call me on the phone and they're like, I don't want to talk to your secretary, I don't want to talk to your assistant, I want to talk to you, because I need to know, like, what do you do, right? And so I explain, you know, like, well, they're like, well, we've been to chiropractic, we've had CST, we've done all the things, like, so how are you going to be different? Or we've even been to speech and we've been to PT, like, how are you different? And so my job is to work with your baby, with their skills. I'm going to work with their reflexes, with their nervous system, and I'm going to get them to do the things that they are designed to do. Babies are really capable, but sometimes things disrupt that. They disrupt those normal movement patterns. And so I'm working with their baby, and it is not a passive modality. So when people say body work, to me, I like to differentiate between an active modality like PT, speech, and OT, where we're working with movement patterns and with that baby, versus a passive modality where that baby is being moved. You know, something on that baby we're doing something to that baby, and they are, you know, passively participating, really. And parents seem to understand that really well. But then the other piece, I actually just did a little Instagram, story or something about this yesterday. But I mean, the thing that I'm always explaining, not just to parents, but especially to other therapists, is that we cannot change structure. Like, if there is an asymmetry and we are stretching that baby, you know, to try to get rid of or fix their torticollis, let's say, we're not going to stretch them through that unless there is strength in place to support a new movement pattern. Because what happens is, yes, we've elongated those muscles and now we have a nice big full range of motion and we've had our adjustment or whatever that day, but then we're going to go back and use that exact same movement pattern that we were 24 hours earlier, and everything just goes right back to the way it was because our body remembers that. And so we have to build strength and coordination to support a new movement pattern if we want things to change. And that's something that like I just am constantly saying and re-saying and saying it differently, because until we understand that, it's not going to change. Yeah. So that's my soapbox about that. For sure.
No, and I love that, because I feel like that, you know, our scopes of practice are in the baby population overlap and are different. It's like a Venn diagram, right? Like
Absolutely.
we have these interlocking, overlapping circles of like feeding overlaps, but we look at slightly different areas of feeding, movement, slightly different overlapping areas, postural control, slightly different overlapping. So I love the fact that you're bringing up, because that's my soapbox too, of feeding starts at the hips, and we as lactation consultants can identify something's not right, but then we often need to refer out to other modalities to again find that root. And yes, range of motion, strength, and coordination are essential for all of the pieces and parts of the entire body. You can have a tongue that is has good range of motion but no strength and no coordination, but if you also have no strength and coordination in the trunk, it's going to impact how your mouth moves.
Totally. And I always tell parents too, is like so many of the exercises and activities that I'm doing with babies, they're based on endurance. And that's something that a lot of people don't understand, especially as you apply it to a baby. Like we know what like endurance running is, right? You run longer than the average person, right? And so when you think about breastfeeding or nursing or bottle feeding, like that is kind of baby's endurance sport. Like they have to do it for 20, 30 minutes at a time, especially if they're not good at it. That is really hard. And so when we're trying to build muscle and change movement patterns, a lot of the things we have to do require a lot of repetition. So, you know, to do it once in the day or to practice something and like, oh, okay, we got their head to turn this way. That's great. But like, it's not going to change a whole lot. So it's like going to the gym. Like you'd rather get these like a few reps in 5, 6, 7 times a day versus doing like, okay, we got one decent session that morning and we're going to do it again maybe the next day. It's not enough. And so when it comes to doing these exercises or activities that we're engaging your babies with, endurance is a really important piece. So I always at minimum do 3 reps of whatever we're doing, because you know the first rep might be okay, the second rep might be a little better, and the third rep should be a lot better, or you're going to see the opposite where by the third rep they're so tired they can't even lift their head up. And that's really telling for parents, because they're like, oh wow, like I thought they could do that. Okay, they have great head control, but actually like it's not, it's awful, it stinks. And you know they've never seen that in isolation because they're just seeing a ball of tension. So
now if you could give these parents one piece of advice, because obviously you and I are on here, we're on social media advocating for healthy feeding relationships regardless of what the modality of feeding is, breast, bottle, cup, whatever. If you could give parents one piece of advice for these young babies, 0 to 6 month babies who are struggling with feeding, what would be the one piece of advice that you would give to parents?
Allow your baby as much opportunity to move as possible, period. So because sometimes we just assume that babies can't do things, and if we don't allow them space and time to figure stuff out in their own bodies, they might never do it. And it's not that they're not capable, sometimes it just takes a little bit longer and we need to give them space. So what that looks like is maybe we're trying to get baby, like they're laying on their belly and you know they have a strong head turning preference to their right side, and we're trying to get them to turn to their left side. And we've been trying, and we've been laying on their left side and singing songs and gently stroking their face, and it's not happening. But it's been like 2 minutes. Keep going. If your baby's not uncomfortable and not yelling at you, and they're just kind of chilling, or they're stirring and they're trying to do something, but you're not really sure what, and they're not turning, don't turn their heads for them. Give them more time. Give them time to figure it out. Like wait 5 minutes, wait 10 minutes. If your baby's still chill and they're still kind of engaging with you, they're cooing, there's some sort of, their eyes are moving, give them time and space to work it out. You'll be surprised. And I often am explaining that to parents and showing them that their babies are actually capable of a lot more than we give them credit for. But we live in the hustle culture. Like everything is like, come on, we got to get our tummy time and we got to do our exercises. We got to go, we got to get our sibling, we got to do all the things. Yeah. And so like, we don't just sit there and watch anymore. It's not common. And so giving them space to move, you know, and the same thing on their, all the positions, but really that's important. And also,
for sure.
Here's another thing. I guess this came up this morning in one of my sessions, but your baby has 4 sides. Your baby is three-dimensional. Yes. Your baby is three-dimensional. So they are not flat. There is not just a top and the bottom. They have 4 sides. So make sure that you are giving both sides, left and right, front and back, all of those sides, give them pressure, give them a chance to be on their sides, because gravity works very differently when we're sideways versus when we're laying on our back or our tummy. Especially if we're working on feeding, most of the time we don't feed laying on our back or laying on our tummy. We feed in side lying. But how often are babies, like, do parents, you mentioned side lying to parents in a session, they're like, oh yeah, we don't really do that.
Yeah. I'm constantly taking babies, right, and doing what I've coined intentional handling, where we are just holding them in different planes and spaces against gravity, right? And it might look like holding them out front where they're leaning forward against gravity. It might look like having them in a tiger in the tree where they're kind of over your arm, and then moving them in different planes in that. And one of my favorite things to do while I'm working with a mom on pumping, finding her flange fit, is to take the baby and put the baby in side lying in that DockATot or on, the couch next to us. And a lot of parents, even if the baby's asleep, I'll put them in side lying asleep, and parents will look at me and be like, can you do that? And I'm like, we are sitting right here. That baby is not good. Your baby, we're watching. Right? We haven't left the room. We're not watching TV. Like, your baby needs to spend time on their side. And a lot of parents are actually really surprised at how often I'm putting their baby on their side in an appointment to hang out and to chill while we're doing other things. And it really is underrated, because we're like, oh, back to sleep, on their back, and tummy time. So yes, I think if any of you out there are watching today, go put your baby on their side, on their left side for a while, and then later today or tomorrow, put them on their right side and let them hang out.
Yeah. You'd be surprised.
Now talk to me about when a parent should actively seek out occupational therapy. As in, we'll hear about all these different things you can take your baby to: chiropractic, craniosacral therapy, craniosacral fascial therapy, Gillespie approach, physical therapy, Reiki, massage, all of these things. When should a parent be like, you know what, I'm going to skip all the other modalities and jump right to OT?
Okay. I mean, I'm biased. So,
I am too.
My lights went off. Hold on. I lost my lights. Ooh. Okay, there we go. They're on a timer in my office, so every now and then we get some nice mood lighting. Well,
I'll tell you mine, and then I want to
tell me.
I
mean, I'm honest.
So normally, again, if I see a baby and I'm like, oh, we just have a little birth tension on the body. They came out, they had a really fast labor and delivery. They had a vacuum assisted labor and delivery. They had a C-section and were kind of pulled through, and we're just like, there's a subtle asymmetry. There's a subtle turn or movement. Usually my first choice is, let's go do one session of osteopathy is one of my favorites. They are medical doctors. I have a couple chiropractors in my area that are like phenomenal, of like, wow, you took that wonky head and got everything symmetrical. I have a couple craniosacral fascial therapists. Gillespie approach is really the one I'm preferring. CST, craniosacral therapy, it's hit or miss for me. I see a lot of parents spend a lot of money on it and really see no results. Every once in a while you'll get a gem of somebody who can really understand the body, but
I have a couple here.
I've got a couple. I'm
only
Los
2.
Angeles, right?
That
I've got some gems. Yes. Usually for those modalities, I'm like 1 or 2, and it's for soft asymmetries where there's good strength in the baby's body. They're not really fussy. They're not colicky. We just need to get things aligned a little bit. And then if 1 or 2 doesn't stick, then I'm usually like, oh, you got to jump to OTPT. If I see a baby and like the whole body is like flat head turn preference, really dysregulated, like not feeding well, not coordinated, their mouth is all wonky, then I'm like, skip those first soft
we need a full
therapies.
body.
We need
Right.
a full body, and that's usually
Yeah.
when I'm jumping. So that's my clinical mentality, again, out of that scope. So
Sure.
would you say that it's a pretty similar thought pattern
Yeah,
for
I mean,
you?
it's interesting because you get babies much earlier than I do. So I'm not referring, parents are calling me almost always as a last resort, which is frustrating. It
Yeah.
depends. I mean, my referral sources are amazing. So I am lucky that I do have like frenectomy providers that will refer to
Yeah.
me before they touch a baby. Not often, but enough. But again, that's when there's a lot of stuff going on, right? We have a whole
Yeah.
like there's stuff happening from all different angles. We've got a fussy baby, we've got a lot of asymmetry, we've got some weakness, we got floppiness, we've got dysregulation, we have gags, we have all the things. When there's more than one or two things going on and it's like systemic, there's this whole body thing happening, they will refer out. And so I mean, I don't get those babies. So, I mean, I do every now and then I get very, very little ones. Oftentimes because I've seen their siblings and their parents know better and they call me before baby's born or like the week baby's born. And they're like, so we know we have a tongue tie. We need to come see you. Let's just get it. Let's just see you now and get everything. And it's very beneficial because even if there's nothing major going on, I'm able to ensure that our trajectory stays as planned, with or without a tongue tie or feeding difficulties. It's really helpful to make sure those pieces are in place. So I would say, I mean, OT, when I'm talking to other practitioners, not speech or PT usually, but when they're saying like, I don't know when to refer to OT versus the other ones, and I've made a map and charted this out, but like OT kind of overlaps all of them in the beginning. And I mean, I am biased, but also that's just the way that we're trained, right? So we are able to work in the mouth and we're able to work on the body stuff, the same stuff that PT does, the same stuff that speech does. That first year of life, really, it's kind of a big overlap. So we sort of are covering all of those bases, but it very, very much depends on the actual provider. Like it depends on, I am not created the same as another OT in Atlanta, could be next door to me, but we all have different training. We have different skill set. We have different backgrounds. So it's important to know who you're sending your baby to and who you're working with and what they're good at. But yeah, I mean, if it's just body stuff, yes,
Now,
body work is
interestingly
better.
enough, I'm out here in Los Angeles and I have sent, I get a lot of virtual consultations through Instagram. Thank you, everybody who's watching and following from the Instagram and YouTube as well, who find me from different areas of the country where they may be in a desert of providers, right? I'm in an oasis, a therapy desert. And so I have often sent babies to you virtually.
Thank you. I appreciate that.
Parents are like, what do you mean I can do virtual occupational therapy? And they usually come back and are like, oh my gosh, I had no idea we could get so much done virtually. Can you talk to me a little bit about what a virtual consultation would look for you and what you can actually do virtually in terms of occupational therapy where you're not touching a baby?
Absolutely. So I'll say before COVID, this didn't seem like a possibility. Who wants to work virtually with babies? That seems like, totally ridiculous. Like you can't wrap your brain around it. But then COVID happened and within a week, everything shut down and everything went virtual. So I had to pivot very fast. I was a little terrified, like the first 2 days I tried it, and then it just became really easy. And so silver lining of COVID now that I'm very good at virtual OT sessions, or wellness sessions, whatever we want to call them, whether they're in state or out of state. So I consult out of state, I'm doing therapy in state, but regardless, I am assisting parents and babies on their feeding journey somehow. I'm doing a lot of coaching. So basically I'm going to walk parents through what a full evaluation looks like. It's still a developmental evaluation. When we first meet, I am looking at a baby's whole body from toes all the way up to their head, their eyes. And what's really cool about a virtual session is that the parents are my hands and the parents are a lot of times my eyes. I'm looking through a computer screen, but it's not always the best. It's a little pixelated, it's a little fuzzy, and sometimes I just don't get the angle that I'm needing, but I'm not always asking them to move their screen. But I've gotten very good at knowing exactly where I need to be positioned and, what I need to see and how I need to see it. And you learn the right questions to ask parents. So the parents it's really neat because when a baby's in my office, I'm doing the assessment and parents are hands-on with their babies, but most of the time it's me and I'm explaining to parents what I'm seeing. And occasionally I'm having them feel what I feel, but in a virtual consult, they're feeling all of it. And I'm saying, okay, now how does this side feel versus this side? Are you feeling any, any tightness over here? When you get your finger in baby's mouth, what are they doing on you? And they have to be very specific, and they're in the driver's seat. And so I gave myself a thumbs up. That's so funny.
How that works.
If I put my
look at that, I gave myself fireworks. That's awesome.
Yeah, see, fun phone tricks. Oh, you have snowflakes. Nope, spirit fingers doesn't do anything.
No, it doesn't do anything.
Thumbs up is magic, apparently. Anyway, virtual calls. Yeah, so they're really powerful. Again, I had a virtual call this morning with a family out of state, and there are limitations, but it just depends. A lot of times my virtual consults are coming from a lactation consultant. So they've already been working with lactation. I've got really good information about what's going on in their mouth. They've often had a tongue or lip tie release, or they're somewhere on that journey, and I've got photographs. I've got a good picture of what's going on in their mouth. This baby that I had this morning did not have a lactation. They weren't working with a lactation consultant. They came to me from a chiropractor, actually. And so we need more information, right? So I'm sending them to a local team that I'm familiar with, and I trust their knowledge, and they're hopefully going to go there and get, that stuff looked at. And I can do oral work virtually. We do a lot of work on the tongue and coordination skills with sucking and whatever we need to, really. But there are limitations. And when I need to know structurally what's happening with this, especially with this baby, they've had a release, but I'm not confident that it was a complete release. And we've got a lot of red flags in terms of the feeding going on that I'm concerned about, and I don't want those to slip through the cracks. So I don't want us to just, grin and bear it until we're 6 months old and we can transition to solids and be fine. I'm not comfortable with that. So I will send them out. Again, it's multidisciplinary. I need all the bases to be covered. So, but most of the time they are. Really, virtual consults have become a big part of my practice, and they're really effective.
Yeah, I found that COVID, you're right, COVID shifted everything. And it really came down to communication skills, right? So that therapist, that lactation consultant, that telehealth medicine, did they have effective communication to verbalize through what they needed parents to do, or did they freeze? And it forced a lot of us to become much better verbal communicators
at explaining what we do.
And honestly, it shifted my practice because I do a lot less hands-on now and a lot more verbal in the lactation realm, right? I'm a lot more hands-off with position and latch, using more verbal skills to make the parent do it themselves instead of, I hate when parents are like, we went to see somebody and they just did it for us, and then we couldn't replicate it
at home.
At home. And the same thing with this, right? Of like, we went to chiropractic, we went to cranial sacral therapy, we went to OT, PT, and they did it to the baby. And then we watched them do it, but then we couldn't replicate it at home. They never gave us a home program. We were never able to do anything. So it became a reliance on a healthcare provider instead of an empowerment to see functional change in the baby.
Absolutely.
So I really think that's also the other key piece, is finding providers that empower and support and help make functional change instead of just having healthcare providers that are like, well, I love to do this and I'm just going to do it for my own fulfillment.
Yeah. I definitely think, I'm glad you brought that up. And the more that I'm working in this like Instagram realm, and I'm doing my campfire chats, and I'm talking to other therapists about what I do, and they're asking me, how do I specifically do virtual calls, and how do I talk through things with therapists, with parents and families, and how do we kind of explain those things? I'm learning that I've definitely honed that craft unintentionally, but because I've had to over the last few years. COVID for sure jump-started that, or it didn't jump-start it, but it forced me to be good at that. You're right. But I think the thing that I talk to other therapists about so often is confidence. Like you said, confidence is key in terms of and I explain this to parents, like, yes, I'm going to make you a home program, but if you leave my office unsure of what to do, I haven't done my job. So even if your baby sleeps through half of our session, you're going to do it with a baby doll, or I'm going to make sure, like, I'm going to demonstrate it, and I'm going to literally make your hands go through the motions so that when you get home, it's not super foreign and you have some sort of a muscle memory for it. And then I'm probably going to have you send me videos of you doing it because I need to hold you accountable. But it's a confidence thing, and I say, like, I'm not going to tell you you're doing it wrong. I'm just going to tell you to tweak something.
Yeah. I love
But
that.
yeah, I mean, it very much is about, they need to leave my office being able to do the things that I'm showing them, 100%. Because if it's not practical, then it's pointless.
Absolutely. Well,
Completely
hey,
pointless.
thank you so much for coming
You
on
are
and
welcome.
talking to us about pediatric occupational therapy, the baby feeding space. I think the big takeaway, again, that I really got from this is put your baby inside lying in
Yeah,
different planes and
move
positions,
them.
because yes, that's something that every parent, regardless of skill, can do today, something that they can take away from this. And if you're struggling with feeding, if you're struggling with a very fussy baby that nothing seems to work, make sure to reach out. I'm obviously always here for virtual and in-person consultations here in my office in Los Angeles, and Nat is a
I'm in
phenomenal
Atlanta.
resource
Yeah.
in Atlanta,
But also
and
wherever you
virtuals as
need to
well.
find me virtually. Cool. Reach out as well.
Around
Thank
the
you, Julie.
world.
Totally.
Thank you so much. I really
You are
appreciate it.
welcome.
And
Happy
we'll
Thursday.
see you. Happy Thursday, and we'll continue to see you on the gram.
Yeah, sounds good. Bye, guys.
All right. Bye.
Thanks.